Choline is easy to oversell because it touches impressive systems: brain signaling, cell membranes, liver fat transport, and fetal development. But the practical question is narrower. Are you low, pregnant or planning pregnancy, lactating, or discussing liver fat metabolism with a clinician? If not, a choline capsule is less like a brain upgrade and more like filling a nutrient accounting line.
So when a video says choline helps anxiety, memory, fatty liver, and pregnancy all at once, what is the honest first filter? Is it asking whether someone actually gets enough choline, or is it jumping straight from mechanism to cure?
Inside the body, a major destination is phosphatidylcholine, a phospholipid used in cell membranes. Think of it as part of the flexible wall around cells and the packaging material for moving fats. That is why choline deficiency shows up in organs that handle lots of fat traffic, especially the liver. The liver connection is logistics, not detox theater. The liver needs phosphatidylcholine to assemble and export fat and lipoprotein particles. If choline intake is very low, some people appear more vulnerable to fat accumulating in the liver, although liver disease itself is far more complicated than one nutrient.
If someone has been told they have fatty liver, should they start choline and expect their scan or enzymes to normalize? Or is that the point where the mechanism is real, but the promise gets too big?
For the brain, the clean mechanism is that choline is a precursor for acetylcholine, a neurotransmitter used in nerve signaling, attention circuits, muscle activation, and autonomic function. But having a precursor does not guarantee that more substrate means better memory. The brain regulates neurotransmission tightly.
What about the anxiety angle? If a study or skin finds lower choline-related signals in a brain region, does that mean taking choline treats anxiety, or could it just be a marker that something else is happening?
Pregnancy is the high-value context because fetal brain and spinal cord development require reliable nutrient supply, and choline also participates in methylation chemistry that affects gene regulation. This is not a boutique, nootropic argument. It is a prenatal adequacy argument, especially because many usual diets do not reach recommended intake. Food matters here. Eggs are a dense source, especially the yolk. Meat, fish, poultry, dairy, some legumes, and certain vegetables contribute too. A recent egg and dash trial in adults with hyperlipidemia found 2 eggs daily raised choline intake without worsening LDL cholesterol or endothelial function over 8 weeks in that control context.
Who should not treat this as a casual add-on? If someone is pregnant, has liver disease, takes several supplements, or already has weird low blood pressure or nausea, should they ask before adding a high-dose product?
The best recent evidence for intake assessment is unusually practical. In a controlled feeding study, plasma choline and betaine distinguished low from adequate choline intake, with the combined markers performing better than either alone. FibroScan also detected increased liver fat in a subset during the very low choline arm, reminding us that response varies by person.
If someone cannot close the gap with food, how should they think about forms? Are choline bitartrate, phosphatidylcholine, and CDP choline basically interchangeable, or should the goal be more modest? Pick a credible product and avoid giant doses?
I would frame dose as a boundary problem. Start by estimating food intake and the choline already inside a prenatal, multivitamin, krill oil, or nootropic stack. Then supplement only the shortfall when there is a clear reason. In research, 1,000 milligrams per day of choline bitartrate clearly moved TMAO, so big doses are biologically active. The gut microbe story is important but unsettled. Some choline is converted by gut microbes into trimethylamine. Then the liver converts that to TMAO. In a randomized crossover study, 1,000 milligrams per day raised TMAO substantially, yet did not worsen insulin sensitivity or glucose tolerance over the short testing windows. That is reassuring, not a lifetime safety guarantee.
What would count as choline helping then? If someone just feels a little sharper on day 2, is that meaningful, or should the outcome be something like corrected low intake, better pregnancy nutrition coverage, or clinician-tracked liver markers?
Exactly. The expected benefit is strongest when the baseline problem is low intake. If choline was already adequate, adding more may do nothing noticeable. For cognition, mood, or liver symptoms, no supplement trial at home should delay evaluation. Choline can be part of nutrition, but it is not a diagnostic shortcut.
What side effects should make someone back off or call for advice? I keep hearing about fishy odor, but are there more serious signals when people push high intakes?
Yes, high intake can cause fishy body odor, sweating, vomiting, low blood pressure, and liver-related concerns. The practical boundary is simple. Do not stack multiple choline sources casually. Do not use it as treatment for cognitive decline or liver disease, and get medical guidance if pregnant, medically complex, or symptomatic.
So the clean takeaway is, choline is a real nutrient with real jobs, especially membranes, acetylcholine, liver fat export, and pregnancy development. But the smartest use is targeted adequacy, not chasing every brain or liver headline. Did I get the latter right?